Hello, everyone. My name is James Callahan from the Michael Garron Hospital IPAC team. I want to thank you today for joining us and welcome you to another LTC CIP group lecture. Today, we have Dr. Marianna Ofner presenting the fourth lecture in our series, Surveillance and Epidemiologic Investigation. Dr. Ofner holds her PhD in epidemiology from the University of Toronto. She is a registered nurse with 34 years experience and has worked in long-term care, community outreach, and has worked with the Public Health Agency of Canada. She is certified in infection control. She is currently the practice lead of the IPAC hub at Sunnybrook Hospital, where she lends her IPAC expertise to a number of long-term care and retirement homes in the surrounding community. And with that, I am pleased to hand over the presentation to Marianna.
Thank you, James. And I'm just going to share my screen here. And there we have it up. Screen share. There we go. As you know, today's lecture is on surveillance, epidemiology, and reporting. And I will be going over the key concepts, focusing mostly on surveillance, because for the LTC CIC, surveillance is quite heavy, and talking a little bit about reporting and epidemiology. So some of the key concepts, I'm just going to move this sharing screen up higher. Okay, so all of us in long-term care need to understand the purpose and definition of surveillance. And an effective program begins by engaging the team in doing a facility risk assessment, which I believe someone else will be talking about, but we're going to be talking about the surveillance component of a facility risk assessment, and setting goals to ensure that data is collected and that the data is consistent, useful, actionable, and timely. Another important concept of surveillance is the reporting. Why are we doing this? What are the opportunities? What are the requirements legally through some of our long-term care acts? And also, what are the mandatory parts of surveillance in long-term care, and how should we be sharing our findings? Okay, next slide. Let's go. Maybe just click. Now it's stopped. Page. Okay, here we go. Surveillance in long-term care. Surveillance, simply put, is just collecting and counting and keeping track of whatever we're looking at. And for us in infection control, it's usually diseases, but it can be things like how frequently we wash our hands, how frequently do we clean and disinfect certain areas. So surveillance collects data that's useful to us, and it's also timely. And examples of this are urinary tract infections, or how many MRSA cases are in our facility. And it helps us to identify whether there's trends happening. So trends can be increasing trends or decreasing trends. And based on what we're seeing and collecting, it helps us determine what interventions we should be doing based on what we're finding. Should we be cleaning more? Should we be getting our vaccination rates higher? Should we be washing our hands more? So a facility risk assessment needs to be done, and the resources necessary to run and establish an effective infection control program include surveillance. So surveillance is part of this facility risk assessment. And what does that mean? It means looking at like the historical outbreaks, what times of the year they occurred, what are the vaccination rates of your residents and your staff. Multiple drug-resistant organisms, are they present when you have new admissions? Do we have colonized residents? And then there's also what is our hand hygiene and glove use rates? And are there any new emerging infectious diseases? So all of these fall under the preview of surveillance. We also often hear words like benchmark, also called baseline or historic data. So typically this is what we use data for, is to measure what we see now versus what we should be seeing. And I do know that CNISP, which is the Canadian Nosocomial Infection Surveillance Program, part of the Public Health Agency, is presently developing long-term care surveillance for Canada. So this will give us information like every flu season, we'll see an average of 12% deaths among residents who get the flu. So when we have a baseline and our baseline is different, so let's say we're seeing 40%, then we can say something's wrong or something's different. This is right out of the APEC, the long-term care textbook, and I just recommend later you guys read it more in detail. But these are the different types of surveillance. And the kind of question you would get during the exam is, what type of surveillance would you use for this? And then they would describe something. And then you would add in one of the types of surveillance. So there's several pages of this. Electronic surveillance is obvious. It's things that are on a computer that are electronic. There are things like electronic medical records. People have certain software that collects this. A lot of us just use, the Microsoft Excel, and we keep information electronically that way. And also, we're all quite familiar with whatever our institution EHR, electronic health records system is. It's good because it reduces the burden of paper, but it also is quite expensive in that the programs can be expensive, and it's also sometimes difficult to link the different databases. So you want pharmacy and lab and surveillance and hospital records all kind of communicating, and sometimes you have to look at 4 different things because they're not merged together. So that would be a big disadvantage if they're not, and most places are not. We talk about house-wide or comprehensive surveillance. And one thing, I found as a nurse, epidemiology or surveillance, everything was like difficult for me initially because it's just, I'm not familiar with the terms. But if you look at a lot of this stuff, it's common sense. So house-wide comprehensive surveillance means we did everybody. We included everyone. We did the whole retirement home, the whole nursing home floor, the whole nursing home. So whenever it's everything that we're looking at or everybody, that's what they call it. So if they say we're doing a survey on everyone, know that the answer is comprehensive. So you can look at infection, but you can also look at things like antibiotic usage. What are all the lab reports finding? And this comprehensive stuff is actually the stuff that we would use in a facility risk assessment. It gives us a big picture of what's going on in our long-term care facility. And it also provides benchmarks that I mentioned earlier, benchmarks, baseline, historic data. What do we typically see? Is this different? And we are always asking ourselves that question. Now, there's challenges to this because it's a lot of information, it's a lot of data, and most of us aren't used to collecting large amounts of data and trying to look at it electronically, because looking at it on paper is really difficult. So it's overwhelming. But one of the good things is about long-term care and retirement homes too, is that our residents are pretty stable. We're not like a hospital where you come in one day and leave the next. We kind of know our group. We know our baseline. We know our people. We know the difference in the floors, whether it's a chronic floor with a dementia floor is different than a people walking around floor. So we're familiar. So that helps. So this is another types of surveillance. So outbreaks, we're all familiar with outbreaks. So, and they're defined in different ways. You don't have to ever decide what the definition is for an outbreak. There are always definitions out there that you can use, and your outbreak management team decides what the case definitions are. And we're going to talk more about case definitions later on. But when we do outbreak surveillance, it's basically looking for anyone who's part of whatever is going on. So if you see increased numbers of people with diarrhea, then we have a gastrointestinal outbreak, and then we decide as part of the group, or you as the infection control practitioner decide, who am I going to count? So is that every new case? Is it people with 2 or more cases of diarrhea? If you do, 2 or 3 more cases of the same infection, that is an outbreak. Is it 2? Is it 3? You decide. You usually work with public health on this. The advantage is that you're identifying cases as quickly as possible, that you can use outbreak protocols. And the disadvantages is it is, as you know, very labor intensive whenever there's an outbreak to try to actively look for cases. And we will talk later on too about active surveillance, where we're actively hunting down people. The reason I have the next two in red is because this is very important and is often will be seen on the exam. So what's the difference between outcome and process surveillance? Outcome surveillance is when we're actually looking at rates, and you hear this: incidence rates, prevalence rates, standardized infection ratios, all to be discussed later on, but we're looking at measuring an outcome. The outcome is I was well, the outcome is now I'm sick, right? So it's something definite. We're looking at an infection, we're looking at diarrhea, we're looking at norovirus, we're looking at a urinary tract infection. So that the outcome that happens to a patient is what we're measuring. Process surveillance, it looks at adherence to steps or techniques used in best practices. So how often is hand hygiene occurring at the bedside? During a norovirus outbreak, how often are we cleaning frequently touched items, equipment? So someone is actually doing the surveillance, marking, checking that off. They're looking at a process. You're doing something as opposed to an outcome. You didn't do anything. That's the result of being exposed, right? So I always find that a lot of these words they use are just kind of common sense. And so when you're asked things during an exam, kind of go, what is that measuring? Is that an outcome or is that a process? And then it's sometimes easy to figure out what they're asking. Now, we hear about prospective and retrospective surveillance. And prospective just means it's something you're gathering moving forward. So moving forward is the most important thing. It's how many new cases are we seeing? Okay, we're going to start prospective surveillance looking at all urinary tract infections starting today or starting the month of February. So February going forward, we're going to collect every new urinary tract infection. So that just means prospective, moving forward. Retrospective, I always think retro, those are my retro clothes, means in the past. So the only way we can know what was going in the past is we pull out old records. So we look at people's medical charts, their electronic health records. We look at old lab reports, how many people ended up having this organism in the last year, and then we pull out the lab reports and we check off. So that's a retrospective surveillance, and the forward is the prospective surveillance. And then there's targeted or priority directed. And I think it's important here because we kind of go, oh my gosh, how do you know when one is the other? It's important to know that you can have multiple surveillance programs. So you can have a targeted prospective surveillance. So I'm looking at just C. difficile cases that were brought into our institution, C. difficile infections that were brought into our long-term care floor that came in from the hospital. That's a targeted one, people coming in, looking just at CDI, and it's prospective going forward. So always, when they word things in the exam, always read it. Sometimes you got to read it a couple times and say, okay, this is what they're doing. They're going forward, so that's prospective. I always have a pen and I write prospective, and they're looking at something targeted. So it's also targeted, but they're not checking medical records, so it's not this. So you X out and you say, okay, it's 1 in 3, and 1 in 3 is the answer. So hopefully that's a good help. Here's an example of a question that they could ask. You're asked to go back into residents' medical charts who are on the 5th floor of the home and look for cases with influenza-like symptoms during the months of November to March. This is what type of surveillance? And I just ask that you pause now and read through these and figure out, based on the question, what is this? So you've unpaused now, and the answer is, you read it again, you're asked to go back into the medical charts. So right away I'm going, okay, I'm going back. So it's retrospective. It's not prospective, so I would X out the thing. Is it comprehensive? No, it's the whole 5th floor. Is it a process? No, it's not a process. They're looking at people with specific illness. So yes, it is C, retrospective surveillance. Here's another question. There are 14 cases of norovirus on the 7th floor. I have to move my face there, of a long-term care home in 1 week. So I always take a pen and paper. I always go 14, and then I notice things like new cases. There's 36 residents, so there's 36 people. So I write 36 down. Management suspects that hand hygiene or frequency of disinfecting commonly touched surfaces is the reason for the increased number of new cases. The IPC lead records so they're recording new cases, frequency of occurrence of hand hygiene, and frequency of disinfection for the 2nd week of this outbreak. What type of surveillance is the IPC lead doing? So they're looking at new cases, right? Yep, so that's incidence, so that's number 1. They're not looking at prevalence. Are they looking at outcomes? So they want to know frequency of new cases. So frequency of new cases means outcomes. So there's 3. And then they also want us to keep track of the frequency and occurrence of hand hygiene and disinfection. So that's the process one, remember? So 1, 3, and 4. And then I look, is 1, 3, and 4 an option? So, because I always find that's the best thing to do. And if the thing you write down isn't one of the option, you got to rethink it through. So I would say C. C is my answer. Let's talk about data collection, tools, spreadsheets, and software. Tools for surveillance collection, they can range from these sophisticated software programs that some people have within their homes, but most people don't. And it can also be like paper line listing, which we're all familiar with that one. Facilities that do not have access to these sophisticated surveillance software programs will often collect and track things on spreadsheets. So we're very familiar with using Excel spreadsheets. And we can place them on secure shared drives so that everyone has access to them. There's also these line lists are great to share with public health during an outbreak, because then they can see what's going on and they can run our epi curves for us. Important things, information to collect. Well, we only want to collect things that have to do with the patient, right? So this includes their name, their medical record, what room they're in, what type of infection they have, their symptoms, culture results, radiology reports, whatever we think is important about this specific organism, right? And it has to be patient specific, so we know who has it, because we have to treat, we have to do contact tracing. So that's why we have all that information about their name, their medical record number, what room they're in. So who they're sharing a room with is why we collect information like that. So here's an example of a question that could be related to this. So a surveillance program for urinary tract infections has been initiated at your home, and you've been instructed to create an Excel spreadsheet line list for all residents with indwelling catheters. Which of the following variables would not be a necessary variable to collect? So you can pause and then read them, and then unpause when you've decided. So, oh, sorry, I'm pausing and I'm not. So now that you've unpaused, you look at, okay, the date the catheter was inserted, the name of the healthcare worker who put the catheter in, list of symptoms, name and room number of residents. So for me, we need to know what's the date it was inserted in, because we want to know potential catheter days. Was it day 1, day 2, day 3? We want to know what symptoms they had, because the symptoms are important for making sure they meet the case definition. And we always collect name and room number. Where are these people located? So it's the name of the healthcare worker who put the catheter in. We don't really need to know who put it in, right? So that would be the one we would choose for this example. So case definitions are a really important part of what we do. And often case definitions already exist. We generally don't have to create case definitions from scratch. If you go on to Public Health Ontario, Ontario Ministry of Health and Long-Term Care, there are often surveillance case definitions posted there. Toronto Public Health and other public health units also have case definitions for what they call a case. This is the one on the left is a surveillance case definition. So if we're looking at C. diff infections, this is an example of a surveillance case definition. If they meet this criteria, then they are, yes, a C. diff infection. And if for outbreaks, there's always outbreak case definitions. And what happens with outbreak is we often have to separate them into confirmed and suspect. Suspect usually means not all of them have lab confirmation, but some of them do. For this one, you have to have one lab confirmed case or 2 people with acute respiratory illness within 48 hours with a common epi link. And so the important thing to remember here is that case definitions meets a specific criteria. You either meet it or you don't meet it. And we often look, and we'll discuss this in the epi section, at person, place, and time and clinical features. Those are usually in the case definition. So you may be asked a question like, what are the important components of a case definition? Person, place, time, clinical features, and they may mention something else. And you say, nope, that's the wrong one, or this is the right one. So that's the important thing to know in red on the bottom. These are other important notes that I just want to make sure they were clear, so I'm going over them again. Whenever I go over things over and over, it usually means I think they're important. So when we're calculating infection rates, the numerator is the numerator, the one on the top, divided by the number on the bottom. So the numerator is the number of residents with the specific infection, and the denominator must accurately reflect the population. So if you're having an outbreak on a floor, you don't take the denominators, not the whole long-term care facility. It is that floor. So always remember when you're reading things that you're making sure that the denominator reflects the population. And again, I give another example here. Indwelling urinary catheters would be the population or group who is at risk for catheter-associated UTIs. So all those who have catheter-associated UTIs are the numerator, and the denominator in this case is not everyone on the floor, but it's everyone with an indwelling urinary catheter. So it includes those people who have a catheter who are sick, and who also those who don't have a UTI. So you always have to make sure that it reflects the population at risk. Again, the second example is residents with central venous catheters will be the population or group at risk for central line associated bloodstream infections. So the denominator in this case is those who have central venous catheters. The numerator are those who have an infection caused by the central venous catheter. And then at other times, such as outbreaks of norovirus or influenza, the denominator may include all the residents because everyone is at risk. The historical incidence rates. So incidence, again, always remember new numbers, and prevalence. Prevalence is what's going on, how many cases, including everyone. This historical stuff is our benchmarks. And we use benchmark data when we're trying to compare standardized infection ratios, which I'll show you how to do that later. One of the things they say, if you have greater than 10% of what's been seen in the past, then that's considered higher than usual. But you also have to look at, what infection is that. The rate, also called proportion or percent. So remember that, because, people use these words interchangeably, must always be with the same number of units to allow comparison over different time periods. So if we can't compare the number of CAUTI versus the whole population on a ward versus catheter-associated UTIs, and those who have indwelling catheters. Like, always make sure, I can't emphasize this enough, and this is the question they want to make sure you're understanding in the exams, is that you're always using the proper denominator, and you're also comparing the proper numbers. So you only would compare two rates that have similar denominators. And rates are usually expressed as per 1,000, although I have seen 10,000, I have seen per 100. And the unit used for the denominator it could be the number of days the resident was in the facility, and this is called per 1,000 residence days, or it could be just per 1,000 residents in the facility. So you'll see, make sure you're always reading carefully what your denominator is. So here's an example of a question you would get. They're always trying to make sure you're thinking, right? To better understand the observed increase in respiratory illness in your long-term care home in the fall of 2022, and whether this was unusual for your facility, your managers ask you to internally benchmark your data. Which of the following is the most appropriate? So pause and figure it out. So this one, you have to think, right? So I'm trying to compare the fall of 2022. So this is like influenza season. Let's pretend COVID isn't around because it complicates things. But it's influenza season. So we want to compare always, like I said, similar timeframes, similar denominators. So what we really want to do is we want to compare October to December 2022, this fall, to last fall. We don't want the year before, the whole data. We don't want the springtime. We don't want to compare full year's data, and we don't want to compare the fall with the same year from January to December. So like the full year versus just the fall, because you're always going to find a difference. We need to compare the fall when flu happens to the fall when flu happens. So this is how to calculate incidence. And so this is right out of the textbook. And I made a circle around this because this is really the most important thing for you to remember with incidence. It's new cases. It's not old cases that you're counting. It's what's from this point on, how many new cases have happened. And you take the number of new cases and you divide it by the number of people at risk. And then you times it by 1,000 and you get your incidence rate. Your prevalence rate is the number of disease occurring during a specific time. So it's anyone, not just the new cases, but old cases that are still active. They all get included. And that's the big distinction. So here's an example. We have 4 people on a 10 resident unit, and they develop new symptoms of UTI during the month of March. To calculate the incidence using a percent, oops, this thing moved up. Let me go back. There we go. Oh, I have to do it this way. So to calculate it, we need to, here we have, it's 4 new UTIs occurred during a specific time period. And then we have 10 people at risk. So you just take it. You take 4 divided by 10. I think I wrote it underneath here. This thing should be moving. Okay. No, it's everything's, yeah. So you go 0.4 times 100. So 40%, if you go 4 over 10, it's 40% of the residents. And then if you want to know for a specific time period. So this would be, we want to know for the month of March. So this is really important here. So when they're asking you to calculate UTIs per resident days, you have to take the number of days and put that over the number of cases. So you go 4 UTIs over 310 days. So we have 10 people who are there for 31 days. So 10 times 31 is 310. And this is the number you get. You times it by 1,000. and then you get 12.9 UTIs per residence days. So whenever they're asking you for residence days, for a certain month, you have to multiply the number of days in that month times the number of people to get the number of days, because you're doing it per resident day. So in the exam, they'll say calculate per resident days, and for the month of March, and you'll get a hint. They'll say there are 31 days in March, or for the first 3 months there are 65 days or 88 days in the first 3 months. So you'll know they want you to take whatever your denominator is and multiply it by the number of days when they're providing you with the number of days. Okay. Page down. Okay, and prevalence is all the cases. So if we ask yourself, what is the prevalence of cases on March the 7th? You may have heard this. This is a point prevalence. It's a point in time. It's just one day. How many cases are on the ward? They often do point prevalence studies. They'll come into an institution and they'll say, let's do a point prevalence on whatever infections are happening on this ward today. So you'll have 7 UTIs and 2 MRSAs and 1 scabies, and hopefully you don't have all those, but so that would be divided by the number of people. So that's a point prevalence. So it's all active cases on that day that you're doing the prevalence. So let's calculate the prevalence of the point prevalence for March the 7th. Based on this information here, I have 3 patients. And maybe we'll pause it and we can look at what the answer is after. So the point prevalence, or what I'm calling percent, this is another time when I think I have the answers behind it here. Yeah. So the point prevalence. So you have two cases of these 3, only 2 of them were actually active on March the 7th. This person, they're diagnosed. That's date of diagnosis is March 3rd. They no longer have symptoms on March the 5th, and we're doing the point prevalence on the 7th, but they're still on antibiotics. And our case definition says if you're still on antibiotics, even if you're not symptomatic, you're still considered a case. So that's a case. This one, date of diagnosis, started antibiotics. So they were diagnosed on March the 7th. So we're going to include them on it. And then this is an older case, diagnosed on February 28th. They're no longer symptomatic, and they finished their antibiotics on March the 5th. So on March the 7th, this person is not symptomatic and not on antibiotics, and therefore not a case. So that's where I got the 2 from. 14 is the number of people on the unit. 2 divided by 14 is 0.14 times 100 is 13.3%. If we want to do it based on resident days, then what we have to do is prevalence by 1,000 residents, so not days. We take for the first 3 months. We want this is here. I'm asking. I think in here I said, what is the prevalence per 1,000 residents? So per 1,000 residents. So you take, and I'm specifying for January, February, and March. So for these 3 months, we only had these 3 cases. That includes everyone. So that's why there's 3 divided by 14 times 1,000, and it's 214 per 1,000 residents. That's the answer. And then the last one, sorry, this is confusing. And it is just paying attention. What is the prevalence per resident days? So how many days for those 3 months? So you have 3 cases, and how I got 88 days is it's January, February, March. January has 30, February has 28, and March has 30. That equals 88 times our denominator, which is 14. So 4 divided by, so 88 times 14 is 1232. That's how many residence days, times 1,000 is 3.2 per 1,000 resident days. And what I'd like you to do at this point is like stop and figure this out, because someone just talking, you lose half the stuff. But if you stop and write it out, okay, I need to figure out residents, you know, and go through and look at all this and be sure that you can figure this out on your own. There we go. And I like this little graph. I've seen one like this and I had to make this. Unfortunately, you can only see these lines. So if someone were to say, what is the incidence between this time period and this time period? You only pick the people who are freshly diagnosed. So this person, this person, this person, and this person. So you have 4 people who, so that's the incidence, 4 out of, and there's 40 people on this unit. So you go 4 out of 40. And then someone says, what's the prevalence between January 30th and February 11th? Then it's every single case that happened between that time period. 1, 2, 3, 4, 5, 6, 7, 8. Doesn't matter where they are. That's the prevalence. Prevalence is everyone. Incidence is new people between a specific time period. Maybe pause it and look at that, because this helps you remember it. I always find this visual is really good. Okay, let's do attack rates now. I wish my picture wasn't always in the way. Okay, attack rates are a specific type of incidence rate. It measures a specific population that exposed to a specific infectious agent during a limited time period, primarily used during outbreaks and epidemics. So, the formula for attack rates are the number of ill people over the number of people who are at risk for developing whatever. So that would be everyone who is exposed, everyone who ate the chicken salad, right? And how many of the people got ill with it. So that's the attack rate. So the important thing with attack rates are, when you see that, you know, what they describe a scenario, what would you use? And you pick attack rates when they're looking at number of people who are ill versus number of people who are at risk. So here's an example. There's a respiratory outbreak was confirmed of influenza A that lasted 22 days. Oh, this is an important thing. They always throw in the exam, they all throw in these numbers. And there were this many people, and during this week, they had the highest number, it was 14. So there's all these, like, I call them distractor numbers. And it always, you know, it freaks me out, because I'm like, okay, which number am I supposed to be focusing on? So you figure out what do they need, and which of all these numbers they're presenting you do I need to pick to calculate my thing. So remember that you don't have to use all the numbers they give you. So the 22 days, oh, are we going to need to throw that in the formula? No. So what we do need to throw in the formula was there were 33 people at risk for influenza who got influenza, and there were 22 people who are at risk, so who didn't get it. So that's called the attack rate. And the attack rate is 15%. It's 33. So I wrote down here at the bottom, this is what I would write on a piece of paper during my exam. I'd read the thing, I'd say, okay, it's 22 days. Okay, there's 33 people with the flu and 22 are at risk. Okay, the 22 days doesn't mean anything. So 33 divided by 22 times 100 is 14.8, or rounded to 15. It has a 15% attack rate. Bump. This is another thing you have to learn, and you just have to learn it. It's called standardized infection ratio. So the number goes between 1 and -1. No, sorry, 0 and 1. That's it. So no, it's -1 and +1. That's it. So if to interpret it, it's the number of observed infections. How many infections did we see divided by the predicted infections? And I always used to go, well, how would I know what they predict? Basically, it's a benchmark, a baseline, or some kind of historic data that you use as your what should be occurring naturally? And is this more, are we observing more than we should? So if we know the benchmark for last year was 50, and I don't know what what example, but were there 50 cases of this? Let's say it's the flu that happened last year. That's the benchmark. We've had 50 cases every year for the last 5 years. So to interpret the standardized infection ratio, if the number is 1, the number of infections reported is the same as the number predicted. So there's no difference. So if there's 50 infections this year divided by 50 infections predicted, then the number is 1. So this year's number of flus is no difference. If the number is less than 1, then that means there are fewer infections reported than what would have been predicted. So if we see 20 infections this year and we divide it by the 15 and the number is less than 1, this is less than 1, it's 0.4, then we know that this is better than expected. We have 20, not 50. And if the number is 70 over 50, then the number is 1.4, and then it's worse than expected. So they may ask you to calculate a standardized infection ratio, or they may ask you to answer a question like this. So in an outbreak investigation, there's an outbreak of gastroenteritis among 15 nursing home residents who went to a holiday picnic, and 30 residents ate the potato salad, and 10 of whom developed gastro. The infection control practitioner is asked to calculate an incident proportion. So a little heads up here, when I saw incidence proportion, I automatically would think you want to do incidence rate. But the word incidence proportion is often used to mean attack rate. So that's just something, write it down. Attack rate equals incidence proportion. They use them interchangeably, and they use them often to try to get you to think about what you're calculating. So what calculation should the infection prevention control person use? Well, we want to know the incidence proportion to determine the risk of illness among the residents who ate the potato salad. So 10 of 30, not 10 of 50. So 10 of 50 would give you an incidence. 10 of 30 would give you an attack. I hope that's clear. And if it's not, stop the video and work it through in your head. And okay, this is another type of question for standardized infection. So again, it's the actual number of infections over the predicted. So the actual number of our infection is 8 and the predicted is 10. Which of the below statements is true? So I always, 8 over 10 is 0.8. 0.8 is less than 1, which is better than expected. So they'll do things like this. So you know it's less than 1, but they have 2 less than 1s in here. And they say worse than expected. Well, it's not worse. It's actually better, right? So be cognizant, figure out, and then look at it. Look at the answer. Okay. Surveillance and epidemiology. We're all really familiar with these terms, so I won't go ad nauseum on them. Active surveillance. I'm actively looking for cases. I'm swabbing everyone who comes in for MRSA. I'm doing fever checks twice daily. That's active surveillance. That means you're actively looking. Passive surveillance is when you count it, when you find it, oh, you're cleaning a resident and somebody feels hot, you take their temperature, and now you see they have a fever, and then you ask them about other symptoms and they tell you their nose is running and they've had a cough all night. That's someone you just found passively. You weren't looking for them, you found them. Signs that say visitors who have symptoms to report to a nurse before visiting. This is another passive surveillance. You're not actively checking every visitors like we did with COVID let's rapidly do the rapid antigen test. Let's ask them all these questions. If they happen to come in and they read this passive surveillance sign, and they see they have symptoms, then you've identified a case through passive surveillance. Elements of a surveillance program. So in long-term care, it's actually mandatory according to the Fixing the Long-Term Care Act to have some kind of surveillance program. And I think we all do them. And this is common sense here. So in the exam, I always say, use your common sense, just read the things. And the one thing that sticks out that doesn't make sense, that's usually, this is the not answer. Or, yeah, I would do this, this, and this. Those are the yes answers. So you select your surveillance type. I was told I have to do a urinary tract infection. Okay, who's the population? Are we doing everyone, or are we just doing people with indwelling catheters? Okay, let's do just indwelling catheters. What are we going to monitor? We're going to monitor those who have infections. I mean, it's just obvious. How long are we going to do this for? We're just going to do it for the month of March, so we get some baseline data. How are we going to identify the cases? Oh, we're going to write a case definition that says you must have this criteria, X, Y, and Z, and then they meet the case definition. What are the data elements we're going to collect? Well, what's important to collect? Well, we need to collect, like we said, room, patient, number of days they had the catheter, what date they put the catheter in, how often it was changed, what were the lab results, what organisms we're finding. You write down, and I can tell you, you don't have to develop all this stuff from scratch. You can always find a line list for UTIs online. There's one through PHO. It lists all the data elements. You don't have to figure this out on your own. How am I going to analyze this? Well, we're just going to look at percent. You decide, percent or incidence, or you ask your director of care, how would you like to see this? You just want it to be consistent, always the same. So when you compare it next year, when you do another month of surveillance, you're comparing resident catheter days to catheter days versus if you want just number of people who had an infection versus number of people who had an infection. Important thing is to make a report. It doesn't have to be a fancy report. It can be a one-page report. These are the numbers we have. It can have a table, it can have a graph, or it can just describe what you're doing. And then making sure that the people who need to know about this know about it. They have copies of it. Steps in an outbreak investigation. We've all done outbreaks in long-term care. The steps are kind of intuitive for us, but we have to be able to identify all the steps. So again, common sense. Established there's an outbreak. What is the outbreak case definition, right? For norovirus, must have 3 cases that are epi-linked and 1 that has a positive sample. But first of all, establish the existence. Okay, we have 3 people on the floor who all have diarrhea and within a day of each other. So who do I need to alert? Director of Care, Toronto Public Health, IPAC. What's the case definition? So you write the case definition. If you think it's noro, then you look up the standard case definition for that. You record and you perform descriptive epidemiology. Descriptive epidemiology just means describing what's going on. So there's 5 cases and there's 40 people on the floor. That's descriptive epidemiology. 5 out of 40 equals X%. That's descriptive epidemiology. And then you can initiate the line list where you list everything, list the important elements they need. If you send it to your local public health, they often will run an epi curve for you. You call the outbreak management team together. You implement the necessary control and preventative measures. You monitor what's going on. You communicate the findings. And then once it's all done, you declare the outbreak is over. Reporting is really important. It's an important part of surveillance. You take your data and develop a report. It doesn't have to be fancy, like I said, and you have to provide the report to those who need it. Directors of care, IPAC, manager, public health. And public health, you actually legally need to report any reportable disease to local public health, and the reportable diseases are listed in the Ontario Health Protection and Promotion Act. In the US, and the reason I'm saying this is because the exam you write is going to be a US exam. They actually have surveillance is required. It's mandatory as part of all the infection control programs within long-term care. It's the NHSN, which stands for National Health Surveillance Network. It's a surveillance tracking system. And it includes in long-term care surveillance for UTI, CDI, MRSA, VRE, hand hygiene, and glove and gown use surveillance. Interesting. So this is their surveillance program that they use in the States, and all long-term care facilities have to report all of these listed there regularly. I forget how often they report, but they do it electronically. They log into the system and they put in their cases. In Ontario, we have the Fixing the Long-Term Care Act of 2021, and based on the regulation in there, the long-term care licensee must ensure that their IPAC program includes infectious disease surveillance. So that's an important and mandatory thing that must be done. And so in Ontario, if long-term care resident gets what's called a reportable disease, which is a disease that's listed in the Health Protection and Promotion Act, they legally have to report it to public health. So the common reportable diseases in long-term care are the gastroenteritis outbreaks, any respiratory infections, COVID, flu, and food poisoning. Those are the three ones that are reportable to public health. These are the most common surveillance programs: UTIs, respiratory, skin and soft tissue, mucosal infections, which include cellulitis and scabies or infected bed sores. And then we have the GI tract infections that happen, which include noro, C. diff, and other GIs. And I listed some that happen in long-term care. So here's an example of a question. The important elements of surveillance programs include, so pause it and figure out what it is. So welcome back. The important thing are tracking the illness associated with the long-term care environment, reviewing the micro reports for antibiotic-resistant organisms, tracking and reporting any healthcare acquired infections as mandated by the province. It's not mandatory in surveillance programs to do environmental sampling. So it's 1, 3, and 4, and 1, 3, and 4 is B. This is how they do questions in the exam. They often have multiple answers, and then you have to, it's very, very common that you have to pick which is the right one based on 3 of the 4 are right. Epidemiology, this is a very short section because surveillance is part of epidemiology, but it basically means epi, on or upon, demo is people, demography is the study of people, and ology is always logos, lology is the study of. So epidemiology is the study of what befalls a population. And when we talk about epidemiology, we're talking about what diseases, what infections befall our population. And we look at the distribution. And when I say distribution, the spread, the rates, the numbers, what determines whether people get sick? Well, nobody wears a mask, then everyone exposed gets sick. So what are the determinants of health? What are specific populations, and how to apply everything we know to control this? So that's basically how epidemiology works. Surveillance is a large part of epidemiology because it takes the data from surveillance, and we look at this data and we look for what they call as associations between exposures and disease. So an example is this: unwashed hands is an exposure, disease is norovirus. Being around a coughing person is the exposure, and the disease is influenza. Having a tick bite is the exposure, Lyme disease is the disease. So the very important key concepts in epidemiology is this, the terms person, place, time, and natural history. So the person, who's getting it, what are their characteristics? They ate the potato salad. They were exposed to a flu case. Where's the place? Our place could be the picnic or on floor 6 of the long-term care home. the time. It's always like the day of the picnic or the week that the first flu cases came in. Part of case definitions for surveillance or outbreak. So what I mean by that is that the person, place, and time is always part of the case definitions when we talk about surveillance and epidemiology. And this is the last slide. Sorry, it's been so long. I was trying to fit everything in. This is really interesting. Change in our present population that I was reading about. We have more elderly now than ever before in history. 2 out of 3 of those 55 plus will require long-term care services. 40% will require a stay in long-term care. Long-term care residents, in the old days, people would die, but now we have very diverse and very complex care residents on our floors, which before we did not see. And there's more and more needs for home care, assisted living, independent care, retirement homes, and long-term care as the baby boomers are all aging. I'm the last year of the baby boomer, and I'm 59, and I'm the last year, so I'm the youngest baby boomer. And then I have 20 years ahead of me, and they're the biggest population. So that's why I think this is really important for those of you who have decided to do your career in long-term care. What a great place to be. There will always be jobs. You will always be helpful, and you'll be taking care of a lot of people for a long time. So that's it. And end of lecture. I will stop my share. And James, any final words? He's probably sleeping. Yeah. Okay, thank you all for coming. And James has joined us.
Great.
And yep.
Yeah, thank you, Marianna. If that last slide didn't motivate you and encourage you on your LTC CIP journey, I don't know what will. I just want to say thank you, Marianna, for your time and attention. What a privilege for our IPAC leads to have had your devoted attention for the last hour and sharing all of your experience from your career. I really appreciated how you brought the content back in the context of challenging the exam. And I'm really confident that any of the IPAC leads that spent the last hour paying attention to you and giving you time and attention are going to be better prepared when to pass the examination. And with that, I want to thank you again for reviewing the content of surveillance and epidemiology for the LTC CIP examination. All right, thanks everybody.
Bye.